Hi everyone, my name is Vladimir and I'm going to show you what does it mean three-dimensional planing for orthodontic surgery. Because usually this stage hidden from the view of my patients and even my assistants, but especially for me, to be honest, it's one of the most wonderful part of preparation for orthodontic surgery. Because it's everything about facial beauty and harmony that we over and over have tried to measure and to express it into some formulas during last 5 centuries as minimum. So it's a little trip deep into every patient's aesthetic proportions. Also you may add a big headphones with favorite music, coffee, and make it without any hurry, because why not if you're really enjoying the process. So here we have another clinical case with one patient. And first of all, this video is used for orthodontic patients as for future as for previous one, and maybe for surgeons who started their first steps in this kind of surgery. So that's why if you're a maxillofacial surgeon with 5 years of experience, for example, maybe this video is not suitable for you and just don't waste time. So what about components? We have CT scans with diagram files, 3-dimensional photos, dental occlusion scans, and standard photos of the patient. Combinations of all these parts and elements together will lead to final point, surgical splints for the desired occlusion. I also use an IPS program by Calais Martin where I pick all these elements together. So it's pretty comfortable to make it step by step to create my planning, and I really like it. Our patient has classic third class of malocclusion. Maybe 1 decade ago the main plan would be maxilla advancement for a couple of millimeters and mandible setback for a couple of millimeters, but not for today, because I can see asymmetrical occlusal plane, lack of the upper lip, dental midlines is not centered and asymmetric in relation to the facial midline. There are many rules for analysis and ratios, but many of them are not acquired work and not generally applicable for today. So basically I use some of them. First of all, determine natural head position and follow an individual reference line on lateral view for every patient, which created by 3 lines, where first one it would be forehead line between globule and tip of the nose. Second one it would be line from anterior point toward to the bridge of the nose with establishing 50 degrees line, and third line will be perpendicular line to the deepest point of the middle ratio, it's nasion. And the last one from nasion to parallel line to the 50 degrees one will call individual reference line. So it looks like a little intro and makes possible to create all perpendicular lines for measuring all vertical ratios and orofacial components. In the next session I check the position of occlusal plane and condyles. After I make the same with dental casts and separate them from the bone fragments. So I've created a patient model, and now I have to separate maxilla from the cranium using level 1 osteotomy. Also I add bilateral executive split osteotomy for the mandible, and final stage will be standard chin osteotomy that I'll show you later. Before jaws movements I compare vertical and manual occlusion. So I've got dental contacts and I can see the same in my hands. I can see nice contact in 3 points as minimum between frontal teeth and second molars with both sides, and I'm almost sure that we won't see a relapse or an open bite in postoperative period. Of course we have disocclusion between premolars or first molars with both sides, but this is not trouble and it's pretty stable. Perfect. Let's move forward and come back to surgical movements, and starting from the aligning of the maxilla. Add raw rotation for the couple degrees. As you can see, 2 reference points of the cunning tips are aligning. Also don't forget about yaw rotation to a couple of millimeters to the right. Honestly, in general, most of this, it's everything about rotations and degrees, because human eyes may control bone steps and distance in millimeters, 1, 3, 5 millimeters, but what about degrees? And I don't mean a 90 angle, I mean 4 degrees, 7 degrees. And here all these tools really helpful to create desirable rotations. After 4 millimeters mandible setback we've got an idle occlusion, but now it looks like a little second class of malocclusion, and the main idea is to create a well proportioned of the lower third. And it means points subnasal and pagonian should be at the long line, which create a more straight and attractive profile, especially for this patient. And here perfect work, chin osteotomy with 3 millimeters advancement in this case. Beautiful. And here you can also add soft tissues on the new facial skeleton and change parameters. And after saving, you create a surgical splint for every movement and prepare this for printer. So it was short, plain and set, and maybe you learned something for your own, and maybe it would be helpful a little bit.